Thank you very much. Thank you very much for the invitation. No, I'm not the true expert in, because no, I would say that no one is an expert, and I will show you why. Or maybe some are experts here, and you will know who. Here are my disclosures, mostly research contracts, some of them related to this talk. So let's go back to physiology. And here is a healthy subject, and here is a COPD patient. And when we are breathing, the tidal volume we generate, or respiratory muscles generate, results from the action of the respiratory muscles, let's say the capacity, on the load, the resistance and elastance of the respiratory system. And as you can see here, in a healthy subject, at baseline, the load is very low. And so we don't use our respiratory muscles that much. And we know that we could use this respiratory muscle a lot more if needed. The problem of the COPD patient is that at baseline, the load is higher because of higher resistance and higher elastance due to intrinsic PEEP, and that the whole capacity of the respiratory muscles is lower due to changes in the diaphragm geometric configuration, let's say. So the patient needs more respiratory muscles, and he has a lower reserve. So it's balanced, but more fragile. And if a healthy subject becomes non-healthy anymore because of pneumonia, for instance, the respiratory load increases. So the healthy subject will use his or her respiratory muscles a little more, but you see that there are still more respiratory muscles to use. So there is still balance and no respiratory failure. Why in the COPD patients, a little like bronchitis, for instance, small respiratory like airway infections, and load will increase, which will exceed the capacity of the respiratory muscles, and this will induce acute respiratory failure. So the reason why we are using NIV in our patients is that we're going to help respiratory muscles to work, and we're going to try to restore the balance and wait for the lung to recover, and then we're going to treat the cause of the acute exacerbation and hope that there's recovery and the patient does not need NIV anymore. So the purpose of this talk is to discuss the interest of combining high-flow nasal therapy and non-invasive ventilation instead of using only non-invasive ventilation. It's not like replacing non-invasive by high-flow. It's giving a high-flow and non-invasive. And there's a rationale there for using high-flow. And we know that in COPD patients, the increase of respiratory loading during acute exacerbation of COPD is due, of course, to an increase of airway resistance, but also and mostly to an increase of intrinsic PEEP due to the increase of airway resistance. So we can expect that due to this property of high-flow therapy, and I will show you how and why, it could help the respiratory system to fight this increase in intrinsic. So high-flow nasal therapy is just the administration of a mixture of air and oxygen, and as you can figure out in COPD patients, we are not that much interested in oxygen because those patients do not need so much oxygen. And gases are heated and humidified, which is improve the tolerance and comfort of the patients, and administration is by nasal cannula. So what interests us here is the fact that gas are heated and humidified, because there is no dryness, and it's going to improve tolerance and comfort. And what really interests us is that this high flow gonna flushes the nasopharyngeal dead space, and this will decrease CO2 reinhalation. And this is quite important because decreasing the reinhalation of CO2 at each breath gonna decrease the stimulation of the central respiratory drive. We don't mind about increasing FiO2, and actually we don't want high FiO2 in COPD patients, so this is not something that we're going to use in a high flow therapy. We're going to use the flow, but not the potential of increasing FiO2. And we also know that high flow therapy has a little PEEP effect that varied between 1 and 3 centimeters of water, depending on the flow and on whether the mouth is open or closed. So, what do we hope here? So, high flow will flushes dead space, which should in turn decrease PaCO2 and decrease respiratory drive, so decrease respiratory rates. And if we decrease respiratory rates, we're going to give more time to expiration, and then intrinsic PEEP should decrease, which will in turn decrease inspiratory loading. On the other side, we're going to apply a little bit of external PEEP, which should compensate this intrinsic PEEP. And altogether, this will improve the load capacity balance and then decrease the acute respiratory failure, the acute respiratory distress per se. So reducing respiratory rate, labored breathing, increase a little bit tidal volume, and decrease PaCO2, and of course, increase comfort. That's what we hope. There's very few data in the literature, and most of them are coming from one team or one team and collaborators, and Stefano Nava's team and Rapisani. This is probably, I would say, the best study in terms of explaining the physiology of how high flow could improve COPD patients. But you have to be aware that this study has not been conducted in patients with acute and chronic respiratory failure, but in stable COPD patients. But I think that what we can find in the results of this study could be interesting to understand how high flow could be beneficial in COPD patients with acute and chronic respiratory failure. So those was 14 COPD patients with stable chronic respiratory failure. It was a crossover study. Standard oxygen versus high flow therapy, 20 and 30 liters per minute, and I forgot, you will see, versus non-invasive ventilation. And those were physiological endpoints. So we have baseline, high flow nasal therapy, 20 liters, 30 liters, and non-invasive. One we can see here is that expiratory time is increasing compared to baseline. It's increasing with high flow therapy, 20 liters and 30 liters. It's pretty the same. It's increasing, but less than with non-invasive. And this is associated with a decrease in respiratory rate that decreased from 24 to 20 with high flow therapy and 18, let's say, with non-invasive. So we see here that the hypothesis that probably high flow therapy could decrease respiratory drive and respiratory rates works. So it works, less than non-invasive, but it works. And as a consequence, we can see that PDI swing and the pressure time product of the diaphragm decreases here. You see the decrease in response to high flow therapy. less than with non-invasive, but they decrease. So there is an effect of high flow therapy on the intensity of the, let's say, the work of breathing, or the intensity of the respiratory muscle contractility. And this happens without major change in PaCO2, but we are talking about stable patients. So this is the first, that was I would say the first physiological studies demonstrating, demonstrating the hypothesis is that we decrease the respiratory rate and the drive, and high flow therapy unloads respiratory muscles, a little less than an invasive, but it works. So in acute on chronic respiratory failure, there is like a couple of small sized studies, but I have chosen to show this one is 54 patients with moderate acute respiratory failure. They say moderate, but it's definitely acute and chronic respiratory failure. So it's mostly, the patient had chronic respiratory disease, mostly COPD. And they had acute hypercapnic respiratory failure with a marked acidosis, pH 7.31, which is, I think, real acidosis. And PaCO2 was 50, between, let's say, 53 and 61, and respiratory rate 26. And patients were randomized. They had non-invasive ventilation. All the patients had non-invasive ventilation because this is recommended by guidelines in acute and chronic respiratory failure in COPD patients. So they had non-invasive ventilation, but they were randomized to have between sessions either standard oxygen or high flow therapy. So all the patients have an IV, but between sessions is high flow or standard oxygen. And we can see that the duration of non-invasive ventilation session was the same in the two groups, but that the duration of break-off sessions, so the period where patient could tolerate to not receive non-invasive ventilation, was a little higher in patients receiving high flow nasal therapy. Second point, changes in the respiratory rate and dyspnea score. So here we have the change in respiratory rates between the non-invasive ventilation session and the break. And you can see that in the high flow nasal therapy, respiratory rate during the break did not increase as much as it did increase in the standard oxygen group. So it seems that high flow nasal therapy prevents the increase in respiratory rate that happens between NIV sessions, which goes in the same direction, saying that maybe decreases respiratory drive and then keep respiratory rate lower. And in terms of dyspnea, we can see here that while dyspnea increased in the standard oxygen group, it did not in the high flow nasal therapy, suggesting that respiratory comfort was better with high flow nasal therapy. So these are, I would say, small physiological outcomes, and definitely we need RCT with more relevant clinical outcome. This is what we need now. I mean, with those results, we cannot say, let's use high flow therapy in every patient with acute and chronic respiratory failure. No, it's not possible. So we are waiting for two different trials. One is a non-inferiority trial from the Cesare Gregoretti group, and Cesare Gregoretti told me that 6 patients remaining to include, and this is a non-inferiority trial comparing high flow therapy and non-invasive ventilation, so it's one versus the other one. And there is an ongoing trial, multi-center trial in France, and this is comparing NIV plus high flow between sessions versus NIV plus standard oxygen between sessions. And this has started and it's not ready to be completed. So in conclusion, high flow nasal therapy in acute and chronic respiratory failure. So right now I would say it's more high flow nasal therapy between NIV session instead of standard oxygen. Few study, small sample size, but those physiological data suggest that it decreases work of breathing, dyspnea, and improves comfort. It seems safe, so there's a report of like dramatic increase in PaCO2 and patients like being in a coma because receiving too much oxygen, but definitely more clinically relevant outcomes are needed. Thank you very much for your attention.